like you have history taking your claim from, it should be specific so that you can judge the candidates. Now, still writing the cases and proofs, simulators, that is, you must pilot test their roles with student volunteers using practice cases before final examination. A situation where people hastily, either in medical schools, gather SPs 2 or 3 days to the exam is a caricature. That cannot make for quality assessment. Checklists are developed based on the written scripts. As I said, probes are follow-up questions, like post-encounter questions. What we call STEM is a clear set of instructions that is pasted on an OSCE station that gives basic information about the problem and directives on the task expected to be performed by the student. At every station, when the candidate comes, he reads it before proceeding. Now, training examiners. Examiners need to be trained so they are familiar with the OSCE assessment format, the requirements and scoring guidelines. This helps to standardize the expectations from examinees as well as the scoring format. Consequently, when you train examiners, inter-rater and intra-rater variances are minimized, and this will lead to high inter-rater and intra-rater reliability, which will lead to reasonable or appropriate decisions as to pass or fail. Training students. Students or candidates need to be trained in the use of OSCE so as to improve their performance. Students will perform poorly without training, and students can perform excessively well if the instrument is poorly designed. Coaching for OSCE assessment should be integrated in usual clinical clerkship so that it becomes natural for students. It takes valuable time and energy to train students if they are expected to score highly in an OSCE examination. Let's talk more about standardized patients. Use of standardized patients is integral to OSCE. SPs must be properly trained to consistently and reliably portray the cases. Poorly trained SPs contribute to lower reliability of the examination process. Scripts for the SPs must be clearly written and detailed enough. Many times, examiners fail to do this. They don't understand the importance of scripts for the SPs, and that's why it should not be hastily done. Lay people, nurses, medical students can be trained as SPs. Yes, there are problems with medical people, but when you train them well, you have no problem, which we have proven over the years. Only SPs who demonstrate consistency in portrayal should be used for actual exams. Security and confidentiality of scripts must be ensured. Mannequins or other anatomical models used must be stored at the right temperature so that they don't become problem, get so hard in a very warm climate like us. We see that happening, and those mannequins cost a fortune. All right? Examination site. Finding an examination site is one of the most difficult tasks in organizing an OSCE. The bigger the space, the more the stations and the circuits are accommodated, and the more the number of students you examine per unit time, and the shorter the overall duration of the examination. If you have a small space, you have less stations, you have less circuits, and less number of students examining per unit time, and the longer the overall duration of examination. So examination site is critical. The smaller the space, the necessity for multiple examination sites. You must think of total examination time in your administration, including orientation of students and examiners. You must ensure examination security, where you have multiple examinations. Then adequate plans to avoid leakage of exam facts are made by confining upcoming candidates, which we have been doing very well in our faculty. Now, scoring at the stations. Use of checklists. Scoring at the stations are done using checklists. Checklists contain information, points, items, or tasks expected to be elicited or performed by the examiner as he or she is being observed by the examinee. Checklists are the marking or scoring guide. The checklist contains about 10 to 30 items. Marks are awarded to the examinee depending on how well the required tasks are performed, including the correct order or sequence of the task. Scores can be categorized as very good, satisfactory, poor, or not done, and marks are awarded accordingly. Note that the marks to be awarded are already fixed and graded on the checklist. You don't alter them. Based on the degree of accuracy of a task performed, a candidate may be awarded full points, half of the points, or not at all if the task was not done. The marks allotted to each item of the checklist is weighted based on the importance of such item by the constructors. It is better to break tasks into bits and award marks in such bits rather than global scoring. For instance, instead of awarding a score for performing an abdominal examination, break it up to inspection, palpation, percussion, and score accordingly. Marks may be deducted because of improper conduct or roughness by the candidate while examining a patient. We must not fail to do this at postgraduate level. Total marks for each station are summed up for each candidate and recorded on the checklist sheet. Global scoring may be used as an aid to determine borderline candidates and determining passing scores. That's what we call standard setting. Overall score for the entire examination could be compensatory or non-compensatory. Compensatory is where you put both sections failed and section passed and you sum up and get your total score. If it's not compensatory, you can say you must pass certain stations no matter what you do. If you didn't pass stations 2, 5, 7, you fail the exam. So we must note that. But now we are doing compensatory scoring. Some regulations may require that the examinee score passing grades on some specific stations as part of conditions for passing the examination. There is electronic scoring which makes things easier.
Hello, sir. I have approximately.
Hello? Hello?
Approximately 10 minutes left.
10 minutes left.
Approximately 10 minutes left.
All right, 10 minutes. All right. This slide tells you about electronic scoring. You can read that later about electronic scoring. But the checklists I've talked a lot about. You will look at the other ones. The things I put down that are clear with notes. Let me give you an example of a checklist, obstetric examination of a pregnant woman, which is on the screen. You can see the task. You can see very well done, poorly done, not done at all. And you can see things that are expected of the candidate. What, like number 4, check for anemia, conjunctival buccal mucosa, and things like that. 5, checks for edema, and the marks are graded depending on the quality of how it was done. Exposing the abdomen adequately, inspect the abdomen and commence, performs abdominal palpation, all those things. They are all like checklists. You can see that each activity is graded depending on how qualitative it is. You can see lower pole palpation and comments, and then you summarize findings. There's some mark for that. You observe the patient's face, how sensitive you are to know where your patient is in pain. Systematic sequence of examination, we have scored for that. And it is if candidate is rough or causing discomfort or pain, to deduct 3 points. That is acceptable. Then maximum score, candidate score, examiner, and signature. Now, what are the things that lead to errors? As I said, some of the inter-rater, the examiner himself is not concentrating. Inter-rater, they are not all well trained. Poorly trained SPs will lead to scoring errors because they may be aiding the students, they may be doing what they shouldn't do, they may not be portraying well. Poorly constructed scripts and checklists will lead to scoring error, random error, of course. Solution to these errors lies in adequate training of the examiners and SPs, as well as well-scripted cases and well-constructed checklists. Now, how do we standard setting? This is a big thing and pass mark. I will run through this. There are certain methods of setting standards and developing passing score. We will come to them later. Borderline means, these are all accepted. Borderline means approach means that after an exam, you have the mean or median score of borderline. For instance, if 50% have been set as pass mark, examiners will decide that all those who are from 47.5 to 49.9 consider borderline. And you take a mean of all those who scored within that range. It may become 48.5, and 48.5 becomes the passing score, no longer 50. This depends on the performance of the cohort. You have normative or relative non-referenced method. And you can say that after the exam, you take the mean of all the scores. Anyone that scored less than 1 standard deviation below the mean fails. So the pass will be from one standard deviation below the mean and upwards. They have criterion of domain reference, which is static or absolute. The examiner can decide that at this point in time, anybody who scores less than 65 in our membership OSCE fails. It is also used. Just as you go for interview and they say in civil service, you must score 60% of them to be found appointable. Or some universities will say your overall score for professorial level will be 70% of everything. Now you have the Angus method, which Samba has talked about, and Angus modified method. Let me say the difference between both is that in the original Angus method, after the examiners have looked at the questions and given their marks, they gather together and they will compare what they have given. And then each person tells you why he's scoring 70, after that they are allowed to revise their scores based on interactions. And then after that, you will take their marks and find the mean. In Angus method, you spare people that question of coming and checking again and discussing and adjusting your marks. That takes another time. So in this Angus modified, they just do that and take their mean. Then we have correction factor. So far in our membership, we have been using correction factor in us. What we do is that after we have scored, we multiply the score by 0.85. The reason for this is that when you interact with patients, you take history, you communicate with patients. There's no way you can do it to say that you have scored 100%. There's no way you examine the pregnant you and say, oh, you have done it so well that cannot be improved upon, you get 100. But because we do item scoring, we intend to do that. A candidate can get 100%. All right? But you know that it's not plausible. And so we have established a correction factor that will multiply whatever free score you have done by 0.85. The implication is that instead of 100 marks, 85% is the maximum mark practically, and that's what we score. And you can defend that because there are a lot of subjective things you do. It is not mathematics, and of course we do the scoring like mathematics using items. So that justifies the use of correction factor. All right, this next one is about correction factor in detail. This one is about data analysis. The good thing about OSCE, when you enter into the computer, you can do analysis, overall examination mean, standard deviation. You can check for Cronbach's alpha, get the reliability factor of that exam, which in any good exam is expected to be up to 0.8. You can get item analysis for each station, item difficulty, that will help you to adjust later. So item analysis will help you to fine-tune station tasks, eliminating ambiguity and construct irrelevance. It also helps you to determine item discrimination index for each station. All right. Current challenges, the aforementioned potential drawbacks, need for regular retraining of examiners, examiner behavior. Some examiners still interfere and interrupt candidates during exams. The use of checklists, people need to study checklists properly. Some will not look at it before the candidates come, and it becomes a guesswork from the examiner. Cases of high inter-rater variability. You see that 3 people in an exam scoring, the scatter is so wide. So we need more training. Need to standardize the training of SPs across the current 3 examination centers. There's need to increase station duration up to 10 minutes for better testing at postgraduate level. There's need for high simulation mannequins. They cost a lot of money, but it can help us to test a lot of things. There's need for electronic scoring using tablet computers. This section has defined the OSCE examination and it's told you the advantages. It is not a new examination format globally, but relatively new in most West African institutions. It has been acclaimed to be a more quality clinical examination format than the traditional long or short case. Its psychometric properties, validity and reliability, as well as fairness, surpassing traditional method. It has wider scope of competencies than the traditional. It is better for peer comparison in performance. It is more difficult to organize than traditional examination, but it takes much shorter time to conduct the actual examination. Training examiners, simulators, and students ensure high quality, valid, reliable, and just examination. There are variants of OSCE, like practical assessment of clinical examination skill, which West African College of Medicine, West African Postgraduate College of Medicine used for their part 1. You have OSLA, which is supposed to be an improvement of traditional objective structured long examination records. Some countries still use OSLA because an improvement of traditional, but it's not as far-reaching as OSCE. Of course, you have OSCE, which you can use in the laboratories of the structural performance examination. They are all in use with same improved psychometric properties. Thank you for listening.